Okay, welcome everyone. Welcome everyone online. We are very pleased to have Marlise Richter here to speak about a topic very relevant to Africa Day, which is about xenophobia and impact on access to healthcare. Those of you in the room who need CPD, I remember there's a text at the back. Okay, over to you, Marlise.
Good afternoon, everyone. I am impressed that people come on a rainy and a cold day to talk about something as sad as xenophobia. When this morning, when I was finalizing my slides, I can actually put my slides up. My friend had sent me, if I can project this, my friend sent me this article about doing a health system analysis according to Black Panther's Wakanda, which sounds more interesting for me to discuss at the session than xenophobia, but we will persist with xenophobia. Lacey kindly gave up his slot. We talk about xenophobia. I've been involved through a number of civil society groups in anti-xenophobia initiatives, and especially with the court case that came out last month. We've been wanting to speak especially to people in the health sector about the implications of the court case. I want to acknowledge people who have made a contribution to this presentation, especially the steering committee members who served with me on Collective Voices for Health Access, the coalition that we started last year in August, and consists of about 100 organizations and individuals who resist health xenophobia specifically and have links with civil society, pressure groups around pushing back against xenophobia more generally. I would like to start by bringing xenophobia into the room. Xenophobia is quite an obtuse term, and it's by no means theoretical. And I thought it would be appropriate to play two short clips of two scenes that I would like for people to look at and to give me some comments on what they think about it. Let me just minimize here, and let's start off with.
When I was there, you were still short. And then now do you find yourself in Villa when you are supposed to do school and everything? You know that SPH goes and counts people during the census and tell me that in Limpopo you have got 5.7 million people, and tell me out of that 5.7 million, 91% do not have medical aid. They are dependent on the state. 9% they will say for medical aid is dependent on 5%. And then they go and give national treasury. When national treasury allocates its budget, they say Limpopo has 5.7 million people, and they subtract the 7%, 9%, and they give you the budget of the 91 to do all this calculation. Now, I am here, instead of using the budget for what it's meant for, I'm operating for what Nangaba wants us to do. And that is why when my people of Limpopo want health services, they can't get it. And that is angering the community. Because you are coming here to I was in George Masai. We are busy operating with Mozambique national everywhere. And you are not even registered anywhere. You are not counted. You are even illegal. And you are abusing me. This is unfair. It's unfair. I can't go to Zimbabwe and get it.
Any responses to those videos? How you make sense of it?
I mean, having worked in Gauteng, I mean, it's a common occurrence for people coming from north of the border. A lot of staff feel, I mean, same as everywhere, they feel burnt out, but there's a significant proportion of patients coming from outside the province, outside the country. But the way in which it's handled is quite difficult and unacceptable. We've had patients turned away on the doorstep of tertiary hospitals, kids that have died through lack of care by administrative staff not accepting them after clinicians have accepted them into ICU. That happens. The same thing happens here. It's just that ours is internal, and we have the same conversations about people from different provinces coming for care and us not getting reimbursed for it. I don't think we take it out as much on the patients, but it's still a concern and it can happen. Yeah.
Any other reactions?
It's pretty brutal. That second line clip here, quite brutal.
Yeah. I think for me, the hardest part is seeing the little toddler at the end, because I don't see him during the shouting at the patient, but then I move to the gate to see the little 2-year-old. You think how he's going to grow up thinking about the country that he's living in. So I think we only are able to establish that we think the second part is of the tip is from Jeffrey. Talking on the 201 has been very well documented in Bela at the end of August, and we're going to speak a little bit more about that when I come to that part of the presentation. I just want to give you a quick outline of what I'm hoping to cover, and it would be structured around giving the legal position. I'm a human rights activist and researcher, and we always premise our work in what the law says. And this is the legal framework around migrant access to healthcare services. And you'll see we start off with the Constitution and a right that I think everyone is very well aware, Section 27, is clear with access to healthcare. I assume if that's someone who wants to be elected in the superior order. Okay. And then very explicitly that no one is allowed to be refused access to emergency care. The Refugee Act says asylum seekers and other refugees have the right to the same basic healthcare services as citizens. The National Health Act is pretty clear, perfectly clear. Pregnant and breastfeeding women and children below the age of 6 are eligible to free healthcare services, and that everyone is entitled to free primary healthcare services. And then the National Uniform Patient Fee Schedule says if you're a refugee, asylum seeker, or undocumented person from SADC, you must be treated like a South African and be means tested for how much you can pay. The way that it plays out is quite tricky, and this is a really useful flow diagram that the Joburg Migrant Health Forum developed. And it says, is my condition serious, yes or no? And it then flows down around whether you, let's go to the yes one. Is my condition serious? Yes. You go to hospital. Is any of this true? Is it an emergency? I'm pregnant. My child is under 6. If that is yes, you're over here. You don't have to pay. If it's no, you might have to pay. And you have to ask, do you have a permit? In the sense of, are you a refugee, asylum seeker, or have residency? Then yes. You will be means tested like a South African. And if it's no, the next question is, are you from a SADC country? If it's no, you'll have to pay. If it's yes, then you are also means tested. So this is a very useful way of determining what the payment fees are for people who weren't born in South Africa. Now, if I were to stop the presentation there, I'm sure there would be people in the room who would roll their eyes and say, of course, laws don't happen in a vacuum. And of course, this needs to be placed within the current public health system, as our colleague at the back has said. And I think the way that I wanted to approach that is to take the second presidential health summit as a useful illustration, illustrating the way the politicization of healthcare and the way that interpretations around it are conflicted. So we have a representation from government, Olive Sashana, who's a special advisor to the presidency, and she had to talk about why we need a second presidential health compact. And she does speak some about the problems that the healthcare system has. She talks about the shortage of healthcare workers, inadequate funding, limited access to healthcare services, and South Africa having one of the highest mortality rates globally. She does pay a note to corruption, and then talking about COVID and saying that we had about 4 million cases, over 100,000 deaths, and we know those deaths are probably underreported. Health activist Mark Hayward doesn't beat about the bush when he talks about, when he was writing about the health summit, the title of his article was Summiting While the Health System Burns. And he talks about how basic healthcare services are collapsing in certain provinces, how Barra doesn't have any food in some instances to feed its patients, that healthcare workers are exhausted and traumatized, and that billions and billions of rands are stolen by corrupt individuals. So I don't think there's any dispute, or I would imagine that people in the room are very aware of how, in what a tenuous situation our healthcare system is. We have a crisis after crisis, epidemics, the COVID pandemic, failing infrastructure, too few healthcare workers, and struggling with mismanagement, maladministration, corruption, and as Tinder Meyer spoke about, having to operate by cell phone life, we were sanctioned for that, how difficult it is being a healthcare worker in the public health system. And how exasperating it must be for healthcare workers who are already overworked to be faced with treating people that some of them might think are undeserving. I think if we have to step even a little bit further away and look at our South African political and socio-economic situation, I don't have to talk much about that. I think many of us probably mull this over, especially at 4 in the morning, around load shedding, violent crime, graft and corruption, the lead up and the tension around the elections, South Africa's unemployment rate being some of the highest in the world, and staggering 6.5 million people who go hungry every day. So this political situation contributes to a sense of desperation, and in some instances manifesting in increasing anti-foreign sentiment. And there's two surveys here that I note. One is HSRC survey who measured attitudes, attitudes towards migrants. About a quarter of the people that they surveyed were opposed to migrants. About half wasn't quite sure how they felt about them. In previous surveys that asked people if they had engaged in xenophobic violence, 3 to 7% of people said that they had engaged in xenophobic violence, and 10 to 13% have said that they might continue doing so in future. To take a step towards the health system again, I'm quoting here a review by Morgana Mayosi and Tony Benatar, who wrote almost 10 years ago in the New England Journal of Medicine about how the health system is plagued by diseases, disparities, inadequate human resources, and then they note the growing population of a rising tide of refugees and economic migrants. And this morning I would like to problematize the sense of a rising tide. In the popular consciousness, there's a sense, and especially an intensification of discourses, especially in social media, that there's a tsunami of undocumented migrants flooding South Africa, that they are taking our jobs and our women, that they're draining South Africa of resources, and that they're perpetuating crime, and especially the link about criminality and migration is exploited by politicians. But yet, if you look at the data that we have available, that is 2 years ago, they estimated that there's just less than 4 million foreign-born people in South Africa. That's 6.6%. That is by no means a tsunami. The World Bank showed that for every employed migrant in South Africa, 2 jobs are created for South Africa. The migrancy as a resource or a potential resource is severely underplayed. What Stats SA also notes is that while international migrants are more likely to be employed than internal migrants, people who cross provincial borders and non-movers, the work that they do is often indecent work, or what the International Labour Organization would say is not decent work. And research shows that about 40% these works are very vulnerable. An example of it being about 40% of them working without an employment contract. So the sense of xenophobia more generally also manifests in national policy. And a review last month by Manji and some colleagues here at ECT, Stefani Pereira, Joel Olivier, and Lucy Pilson, did a review of government policy to see how they deal with migration. And what they found is that the discourse of policy documents, and this is not just health documents, policy generally across South Africa, positions migration as a problem, and it includes policies where the migration is not an issue. They're blind to migration, or they talk about migration as being a threat. And the sense of migration being a threat to national security is particularly prominent in some of the policies. They conclude that this reflects and also contributes to the xenophobic narratives in South Africa, and it reflects assertions of exclusive nationalism and seeing cross-border migrants as threats. So that is in policy documents, and xenophobia manifests in institutional hostility towards migrants. Got some examples here from Oren Motsoaledi, who I would say was a cheap xenophobe, where he has done immense harm, not only in his position as Minister of Health, in fueling xenophobic sentiments, but also as the Minister of Home Affairs. The foreign migrants are burdening the South African health system, which we were speaking at the nurses conference in 2018. This is more recently in 2022, where he asserted that over 70% of women in Messina are Zimbabweans. We just heard what the MC and Limpopo had said about Zimbabweans being charity cases and breaking our health or killing our health system. And they're not taking any nonsense. We'll speak a little bit about how she's reacted. What often happens, and specifically in terms of government responses to xenophobia, is that governments are either silent, they have no opinion or no comment on leaders making xenophobic remarks. They don't hold people accountable for xenophobia, or they give really insipid responses, like the president here, who softly speaks about the MNC could have spoken about her frustrations in a different way. And government's lack of action, proactive action, and holding people accountable is often read as condemnation of some of the xenophobic sentiments that are being expressed, and that they might even be supporting some of those xenophobic sentiments. I want to turn now to Operation Dudula, and start off. This is definitely not the first instance of xenophobia, or specifically health xenophobia, that Operation Dudula was involved in. But more recently in Kolofong Hospital in August 2022, they had a very specific campaign where they tried to turn people away from Kolofong. This is a quote from one of the security guards that talked about how they greeted patients who were of a dark skin color one by one to check what language they were speaking and to listen to their accent. If you couldn't understand Tswana or Pedi, they turned you away. Even more recently, the attacks at JP Clinic in February, where what Operation Dudula perceived as foreign migrants were turned away from the clinic or even violently attacked. And I think it is important to note that these instances create a consciousness around migration and South Africa being overrun by people who are othered, and that it not only has an impact on migrants, but also has an impact on South Africans, of course, and I'm not just speaking inhibiting health-seeking behavior or chasing people away from healthcare services or putting barriers in place in terms of health promotion and health-seeking behavior. This is a quote from Mia Milan, who was talking about how a Venda-speaking woman was turned away from Kolofong. And in the emphasis on producing documents, as we heard in the clip around Operation Dudula and the Deputy Clinic, the emphasis on having official documents, statistics has shown that up to 12% of South Africans, people born in South Africa, don't have an ID document. So if there's such an emphasis on producing an ID document, what impact does that have on people born in South Africa who doesn't have that documentation? So civil society has been pushing back, as they've done for many years, against xenophobia generally and health xenophobia specifically. And I just want to give a couple of examples of recent advocacy campaigns. This is the Treatment Action Campaign that they attacked Congress in August last year, where the Minister of Health, his credit, attended, and that he was under fire for his lack of attention to xenophobia and his need to speak up. Africa Check was wonderful as usual, bringing out very clear data to counter what Motsoaledi was saying, and being clear that there's no data that supports that 80% of women who give birth in South African hospitals are undocumented Zimbabweans. Health professional councils have spoken out. SAMA was clear that what the MEC and the POPO did was unethical, and brought out some statements around that. There was a large outcry against the MEC and the POPO, and there seemed to have been a big stream of complaints to the HPCSA, which we think was the reason why the HPC dealt with the complaint much quicker than some of the other complaints that they've had. This is an example of the complaint we lodged with some other civil society organizations about the MEC's conduct. And it is, I think, important to note that this xenophobic outburst didn't happen in a vacuum. There's very specific strategic and political reasons for her to say what she said at the end of August. The Department of Limpopo, or the Department of Health in Limpopo, is a beleaguered institution. They were placed in administration in 2011 by Cabinet because of their lack of financial management and high level of administration. The Hawks were investigating them for irregular PPE procurement for millions of rands in September 2021. They had negligence claims of up to 14 billion rand in 2014. And a month before the video, a month before she shouted at the Zimbabwean patient, the Hawks raided the Department of Health officers in terms of the PPE scandal. So her argument, or the fact that she scapegoating migrants for the problems of the department, are clearly false, and is directing attention away for the corruption and mismanagement for the departments that she is responsible for. HPCSA, surprisingly, held her guilty of unprofessional conduct and unbecoming behavior. We felt that this was a limp sanction. We would have liked to see something more strong. The MEC was wasn't very perturbed. She has appealed, and that case is still ongoing. The HPC's Professional Conduct Committee will sit in July to take the complaint further. In terms of the attack on Jeppe Street Clinic, our collective voices brought up statements and engaged the media on it. The media was interested, the department, the Minister of Health was very interested. We asked repeatedly if we can meet with him and the MEC of Health and Gauteng to collectively brainstorm strategies on how we can deal with health xenophobia, not just in Gauteng, but more broadly. We wrote him up and we never had a response. We also didn't have a response to the open letter that we published. He was, however, willing to meet with Operation Zadula during the colourful actions, which we did point out to him, but I didn't have a response. The last point of more recent advocacy initiatives is a case that was launched yesterday, where the Socioeconomic Rights Institute, together with civil society organizations, Kopenhagen, Africa Against Xenophobia, and others, are seeking interdict against Operation Zadula for attacking hawkers, for preventing people from accessing healthcare, something like wearing police uniforms, which is illegal. And that case we will follow with interest. So what I would like to do in the last part of my presentation is to talk just briefly about a case last month in the Gauteng High Court that Section 27 spearheaded. And you can see the full title of the case there. And it included a number of amicus friends of the court. Centre for Child Law, the Commission of Jurists, Amnesty International, a number of UN special rapporteurs who provided legal input into the case in support of the application of Section 27. There was also a range of experts in the court papers. So Section 27 in their article, in their papers, and I just want to note that all the references that I have in the presentation are put in a box at the bottom, and the presentation will be available if you want to look at the court papers or look at some of the research that I cite. So Section 27 in the court papers note how they've got a paralegal office, they situate in Braamfontein, and that there would be many clients who would come, especially pregnant women and children, who are not expected to pay for services, and who would come to them and say that that payment is being demanded from them. There's a particularly noxious Gauteng internal policy, two of them that were introduced in 2020, that noted that only South African citizens and refugees can access healthcare services for free, and that asylum seekers, undocumented migrants, and stateless people were expected to pay. So the case essentially challenges these circulars and directives and saying that you can't, internal policy or a provincial policy can't be in conflict with national laws, where our national framework is very clear about who can access healthcare services for free. So this example in the Section 27 case really broke my heart, and it's another example of 2019. So even before the circulars were included in healthcare services operation, is with the Section 27 is very clear that this is just an example of many other cases of a 2-year-old who had ingested rat poison and a Zimbabwean child, and the family took him to Charlotte for urgent care. But the mom was told before he could be treated, she had to open a file in the admin office. And with the administrator, she was told that he either has to produce a birth certificate for him or had to pay 5,000 rand. It was clearly an emergency. He had been referred on from the Norwalk Community Care Centre with the doctor's note saying he's ingested rat poison. So the mum had to call her family members to come and pick her up from Parktown, and then to go home to get his birth certificate. The disease's condition worsened during this time, and they tried to get him to go to the Marlise hospital, and he died on the way. A death that clearly could have been prevented if the hospital treated him when he presented. One of the second applicants, and I'm not going to go through the affidavits of all the applicants, but I think Kamba Azama's submission in the court documents are very powerful. She's the second applicant. She's an asylum seeker from the DRC. She's been in South Africa since 2008. And in June 2016, she went to renew her asylum seeking permit in Pretoria, which is already an ordeal because refugee reception officers and home affairs is by no means welcoming places. She was 6 months pregnant at the time. And on the way to the centre, she was assaulted and robbed. So she presented as visibly distressed. Her clothes were torn. She was bleeding. And when she went to the police station, the police told her she had to go to a health facility before they could open a case. So she went to the Pico Academic Hospital, where she was told she had to pay 2,000 rand to open a file. Despite the fact that she was pregnant, that she had experienced assault and was entitled to free healthcare services. She received no treatment in this instance, and then a few months later, she had to go for antenatal care at Yeovil Clinic. And she had high blood pressure, something that she already had when she arrived in South Africa in 2008. And the high blood pressure posed a risk to her pregnancy, so she had to go to She went to the hospital twice in August, and she was told every time she had to pay 20,000 rand to open a file or allowed to give birth. This amount was unaffordable to her. Both her and her husband were unemployed, and she sought help from Section 27, who wrote to the CEO of Charlotte Richter, who eventually granted Kamba an appointment, but the night before she had the appointment, she had to be rushed to hospital and she lost her baby. So these are some of the examples that are cited in the court case. And the legal papers were very strong, and the case had a number of process delays. So the founding, the notice of motion was served in, I think it was April 22. Let's just have a quick look. It was in April 22, and the department, it was in May 2022. In July, the Department of Health and others made it clear that they intend to oppose. But then there were significant delays in them submitting their papers. So they had to say why they are opposing the relief that Section 27 was seeking. it became so bad that the case was placed under case management, which is really embarrassing. You're so delayed that the court intervenes in this way. And then last month, surprisingly or unexpectedly, the department withdrew their notice to oppose, and then eventually they agreed to a court order, and that's what I want to look at this morning. So the court order is very clear. It's basically what Section 27 asked for. The court, in summary, upheld the right of all pregnant and lactating women and children under 6, regardless of their nationality or documentation, to access free healthcare services for all public health establishments. These funny Gauteng regulations that denied free healthcare or were quite ambiguous were declared unlawful, and the department was ordered that they had to amend its policy by October. The court was also proactive in saying that any circulars that were in contravention of the national laws would be invalid. The Department of Health ordered that a draft circular had to be circulated by the department within a month of the court order, and that the National Department of Health has to display all posters and health establishments that were very clear about the rights of mums and children. And then what I particularly like is that the Department of Health has to appear in court in October 2023 to report back on its compliance. So the value of the case is that it affirms a position that is already very clear in law, and that we can use to unequivocally challenge some of the internal memos or directives that health institutions or the provincial departments of health circulate to try and prevent access to healthcare for migrants. This is a really useful booklet that Section 27 produced that gives more of a detailed background to the legal framework and some of the work that they've been doing for many years now to try and get a clear answer from government about these rights. And in our conclusion, I really emphasize the importance of challenging health xenophobia in whatever form or way it manifests. I think for me, some of the hard parts of those videos that we saw at the beginning is the fact that so many people keep quiet. Like with the MEC, you hear the staff who's taking around, like laughing at what she's saying. And there's no one who speaks up, say what you're doing to this patient is completely unacceptable. In the GP clinic, you just see all those patients keeping their heads down while Operation Medulla is escorting people out of the hospital. And the fact that if there are more people who speak out about health xenophobia, it's an important pushback against what is happening, and also the symbolic space that is being created in the pushback to it. I think one example that I just suddenly thought of is when there was Operation Medulla, or there was a splinter cell with Operation Medulla, said that they weren't responsible for it. But I think last year in November there was a march to Richter for Operation Medulla, wanting to question Richter about the migrant appointments that they've done, and they moved from Mowbray's taxi rank to the top of Richter. And I live in Mowbray, so I'm very much aware of the number of migrants who live near the taxi rank. And the amount of fear that they generated in their march. So as a community, we did a counter march, tracking the same route as Operation Medulla, and trying to undo what we call symbolic violence done by Operation Medulla. We handed over a memorandum of support to the Kritski administration. So being able to push back in very public ways against the sense of xenophobia, I think is important. I think it's important for us to monitor compliance with the court order. I would very much like to see those posters up in health facilities. And we're speaking to Section 27, how in different networks we might be able to give feedback on how this court order is being implemented in different areas in South Africa. Then the last 2 points is around vigilance and pushing back against suggestions that South Africa erodes the rights of migrants, and especially withdrawing from international obligations. So in the ANC policy conference we had last July, one of their resolutions where they encourage the government to reassess their ascension of the Convention of 1951, which relates to the status of refugees, and the protocol without reservation. So trying to, because these conventions are used as noting the rights of refugees, wanting to backtrack on those obligations, and that we have to be very vigilant and push back against that. And then my last point is, especially in our engagement on the National Health Insurance Bill, in the current format of it, it excludes some migrants from healthcare services, and that is something that many organisations are very vocal about. You'll see in producing a list, I think by Friday, within the Portfolio Committee on Health, to see what legislative changes they would consider to the bill. And that's something I think many people have put submissions into, to have the bill cover everyone in terms of specific healthcare services. So that's also something to keep an eye on. Now I'm going to keep quiet. Thank you.
Thanks, Marlise. We'll open it up for questions. That's a very depressing account, but also a positive account because there was response possible. And we have quite a few people online. So, not in the room, I want to ask you to raise any comments. Thank you. First. It looks like she's going to say something.
I'll ask a general question. Yeah. The presentation you've given goes very much from an activist perspective, but maybe in the context of where we are now, what's the role of academia in this respect? Like, what can I do?
So the question is around what academia can do, and I think if we look at, so part of the work that the collective Voices has done is to do some research around the last 20 years of pushback against xenophobia. And some of our colleagues produced a rigorous audit of pushback strategies since the early 2000s up to now. And I think what for me stands out is the leading role that academics and researchers have played in pushing back against xenophobia and doing research that shows, in terms of the health sector specifically, that's where my interest lies, the far-reaching individual harm that gets done by xenophobia, but importantly, the public health harm that gets done if you exclude people from healthcare services. I think, especially during COVID, that was very well documented in terms of the push to have migrants specifically included in the way that EVDS was functioning to try and get people to vaccinate, but much more broadly in terms of healthcare services. So the research that South Africa has produced has been, I think, the basis of which the advocacy has worked from. And then, I mean, like Africa Check, that's really vigilant around some of the xenophobia and using that research. HSRC, the School of Public Health here, I'm affiliated to the African Centre for Migration and Society at BITS, that is very clear on the evidence base of migration. So definitely in terms of the work that academics do in including migration within their research lanes, whether they are migration research or not, and doing policy advocacy around the research that they've done, I think is absolutely key. And we've seen, if you just take the example of the Portfolio Committee of Health in the NHI, how many academics would give input into the NHI bill and noting the issues of migration? So yes, I think there's a lot that academics can do and that they have done That's important. Yes, I don't think.
Any comments from? There's a hand from the participant. I can't quite see who the participant is, but go ahead. Go ahead. Nsiki, over to you.
Thanks, Marlise. Thanks, Leslie. Yeah, that was wonderful. And I mean, we appreciate the milestones and your efforts and that of others. My question, I mean, we're looking at health xenophobia. So in our case, we have an activity for first year students where we ask them to look out for instances where there have been human rights violations in South Africa. There's never a shortage of cases. And specifically looking at South African cases, we've had to limit that. But as we're looking at this, I mean, we're talking about policy failures. And if we're looking at the intention of the NHI, it is really to extend health to all. So my question is, in the current context, where we know that we have people from other countries who are not documented. We also have South Africans who are not documented. When we talk about access to healthcare, how do we qualify that in a context where we have policy failures and where implementation sometimes of existing policies is not fair and just, and it's erratic at times. And in fact, if I can make an example, I remember before my father passed, he had an operation and went home and needed to get treatment from our local clinic. The staff there, I mean, it was before 4 o'clock. They just turned around and they said, take him to the local doctor. Fortunately, we had a car and we could do that. But if you're looking at that example, we're talking about somebody who is a resident in South Africa and a citizen and who is documented but does not have access to healthcare. So how do we qualify that, and how do we manage, these discrepancies? Because I mean, if one is looking at access, it's an everyday challenge. It's not just about, who is documented and who is not. So I mean, I'm not perhaps asking a question, but I'm just making a comment around the everyday challenges that we face in accessing healthcare.
Yeah, I think you're absolutely right. And I think the immense frustration and healthcare workers and health administrators, their frustration and feeling overwhelmed in which the system, and many instances the broken system in which they work, pose so many challenges. And to add a layer of migration to that, I think gives one more insight into the challenges and the frustrations that healthcare workers have. And I think that raises much broader questions about fixing the healthcare system and the structural issues that are inherent in the healthcare system failing. And I think the issues around corruption and risks and maladministration are key components to that. And being able to work on a broader scale, not just on a I think that focusing on xenophobia is useful, but it has to be set against the background of many of the broader questions around health and human rights.
Okay, thanks. Gavin, thank you.
Thanks very much for the lovely talk that you've given. But I'm just interested in what advice you would give to a health department, let's say the Western Cape Health Department. So legally, we obliged to give treatment to pregnant women, children, emergency care, and infectious diseases for migrants. That's legal. Morally, we should provide care to everyone who can't afford care in the private sector. So what advice would you give to either policymakers or healthcare managers or clinicians seeing people for what contraception, chronic diseases, etc. Everyday medical care that they need. Thanks.
And ones that are exempted from free healthcare services. Your question is related to that.
Yes, yeah.
So, Kevin, I think that flow chart is quite clinical, but it does provide the guidance around who should be means tested and who shouldn't be. And I think to work within those frameworks and the user fees that are levied, I think is important. I don't have much guidance aside from that, and I think it doesn't speak to probably some of the frustrations that you and your colleagues are feeling.
So in other words, it's applying what would apply for South Africans to applying it to migrants, and if they can't afford it, then treat them as South Africans.
Yeah.
Well, that might or might not be possible for the health department. Gavin, you want to respond?
Yes, that of course raises financial challenges in the face of a shrinking real budget. But then and of course morally we should be doing that. But then to push you just a little bit, what about super specialist care, highly specialized care, where people are referred from other countries, potentially because the service is not available there? And this could be cancer treatment, transplants, complex surgery, etc. And what do you think our response should be for requests of those nature?
Again, I would assume that cases like this would have to go through the referral system within the public health structures already. And it would be ideal if everyone could get all the healthcare for free that they needed. But in that instance, again, you would have to follow the guidelines around who should pay and who should not pay. And I can't provide much more aside from that flow chart about who should pay and who should it be provided for free.
But I mean, if it's sort of somebody who's outside the country who's referred in, there's a whole procedure around you have to have insurance, you have to have cover, which is different to refugees in the country, yeah, or migrants in the country.
Yeah.
For those of you sitting here, any comments on that? So I have a question actually. So we do a lot of work with health committees in the community who are the voice of the community in relation to services and back. And I'm sort of like thinking, what would happen if we actually presented this in a forum in Khayelitsha? And would Operation Dudula rear its head in our midst, and how would we deal with it? But maybe that's something to do, that the health committees function in the service, and maybe ameliorating the impacts of xenophobia through local community structures would be an important strategy.
I think that's a very important component. And part of the difficulties of this court case is that we can speak about it in terms of the law and what the courts say. And clinicians would come to us and say it is so hard when they are talking to their departments about this, and how important it is to do education around it. And the examples that you mentioned, Lacey, is exactly this is where some of that knowledge should go. And I should go and do my presentation at Khayelitsha and be able to take those questions there. I think the experiences of the treatment action campaign is where this is included in treatment literacy, and the fact that the treatment action campaign has a very strong anti-xenophobia stance comes from their members, and that I would imagine that with clinic committees one would be able to do the same education and same political engagement around it.
I'll take you up on it.
Okay.
On Africa Day.
Nice.
Any other comments or suggestions? If not, we're now at 12:59. I want to thank Marlise, who I forgot to introduce also as an honorary research associate with our school, after having battled for 5 months to get the appointment process, which did succeed, and is also with the Health Justice Initiative. So thanks so much for this talk. It's given us a lot of ideas, and I'm going to talk to you on the way to the cafeteria to discuss further. Okay, thanks everybody. Thanks all.
Thank you.
And you said you were going to distribute the PowerPoint.
So Carmen, you can email me, and Carmen will also have the PowerPoint.
Okay, thank you everybody. Go well, those of you online. Thanks for the clapping. It's people clapping too.
Is it? That's very sweet.